Good evening, ladies and gentlemen. It is a great pleasure to be with you again during the second edition of the International Lipid Expert Panel webinars. After the very successful first edition, when we had an opportunity to meet with almost 900 participants from 75 countries, I believe it will be another great opportunity to meet with you, to discuss with you about very debatable issues related and associated to lipid-lowering therapy, atherosclerosis, and preventive cardiology. The first two webinars of the second edition of the International Lipid Expert webinars will be completely dedicated to nutraceuticals, because we know it very well that most of the nutraceuticals usually self-administered by our patients. And usually most of these nutraceuticals are not evidence-based, with not evidence-based medicine concerning the efficacy and safety. So we would like to give you the full knowledge how to do it correctly and which nutraceuticals indeed might help in the optimization of the therapy. So it is my great pleasure to be this evening with my great friends and experts in this field, Professor Dan Gaita from Timisoara, Romania. Dan, hello.
Professor nice to see you. Nice to hear you.
Professor Peter Penson from Liverpool, UK. Peter, hello. And Professor Matteo Pirro from Perugia, Italy. So it is indeed a great pleasure to have you all. And we don't want to delay and prolong the introduction, because I believe the most important issue would be to have a nice discussion with you after our lectures. But I believe our lectures will be very helpful for you to have these questions, because during these lectures we would like to answer the most important questions: why nutraceuticals might be useful, why we should look for the different properties of nutraceuticals, and we should expect those nutraceuticals, which nutraceuticals have evidence-based medicine concerning efficacy and safety. And finally, I believe that Professor Matteo Pirro would be able to present you some real-life cases to give you the best examples how to use nutraceuticals and what patients might benefit the most from nutraceuticals. So if you don't mind, I will ask Professor Peter Penson as a first lecturer to start with his presentation about the properties of nutraceuticals, what should be the best properties of nutraceuticals, and why we simply need them. What is the comparison between the diet and nutraceuticals? Why nutraceuticals might be simply useful in our patients when we try to be effective in the lipid-lowering therapy. So, Peter, the floor is yours. Thank you very much.
Well, thank you very much, Maciej, for the kind introduction and for the invitation to speak with my distinguished colleagues and friends. I'm going to give a brief overview of the past, present, and future of nutraceuticals, particularly with respect to lipids and cardiovascular disease. These are my declarations, and then let's start with the definition. So the word nutraceutical was invented in the 1980s by Stephen De Felice, and it's a portmanteau term from nutrient and pharmaceutical. And De Felice described a nutraceutical as food or parts of food that provide medical or health benefits, including the prevention and treatment of disease. So the word is quite new, but the concept is indeed very old. And Hippocrates said to us, "Let food be thy medicine, and medicine be thy food." And I think that's really what we're dealing with here. There have been some attempts to differentiate nutraceuticals from foods, and particularly functional foods. If we think about taking a herb or a fruit and preparing it perhaps as a drink, that might be a functional food, something similar in appearance to a conventional food which might be consumed as part of the diet. This can be differentiated from a nutraceutical, which is a product produced from a food but sold in a medicinal dosage form, perhaps a tablet or a capsule. It's been argued by some scientists that perhaps these terms aren't sufficiently precise enough, and there's maybe something in that. But what I see here is perhaps a gradient. As we move towards nutraceuticals, we see products that are more amenable to standardization, probably cost a bit more, but are also more amenable to evidence-based medicine. It's not a new concept to take something from nature and to turn it into a pharmaceutical. In the cardiovascular sphere, we're of course familiar with the antiplatelet aspirin, which comes from willow bark. We're familiar with digoxin, which comes from digitalis, the foxglove. And of very recent interest, we're interested, of course, in colchicine, which comes from sorry, my slide is stuck. Colchicine comes from the crocus plant and is it has been really interesting in the Lodoco trials and the Colcott trials for its investigated for its anti-inflammatory effects in atherosclerotic cardiovascular disease. Those three examples we perhaps wouldn't consider to be nutraceuticals because they're derived from natural remedies rather than from foods, but they show us, I think, the power of taking something from nature and standardizing it in a pharmaceutical format. Some people then will ask the question, if nutraceuticals come from foods, can't we just recommend that people have a healthy diet instead of taking nutraceuticals? And I would argue that perhaps nutraceuticals are an adjunct or complementary to a good diet. Of course, in terms of macronutrients, we have to advise people to get healthy sources of macronutrients in their diet. We can't really replace that with a nutraceutical preparation. But nutraceuticals, I think, exploit the drug-like properties of food components. And they overcome some of the complications that we might experience if we tried to get those drug-like molecules from food itself. And these complications include variation in the concentration of active ingredients, perhaps between different batches of foods. We might also come across problems with seasonal availability of foods. If we're taking something as a medicine, we want to be able to get hold of it all year round. Some active ingredients in foods might be really good for us, but they might be present in low concentrations in foods, and we might have to eat rather a lot of that food to get a beneficial quantity, and that might be inconvenient or incompatible. We also might want to get the health benefits of numerous different multiple ingredients from different foods, and that might be hard to combine in a standard diet. And of course, cooking processes may alter the chemical composition of these chemicals. And so I'm very briefly going to give two examples where I think some of these problems in terms of getting beneficial molecules from food have been overcome in nutraceutical settings. The first example is omega-3 fatty acids. These are present in oily fish and have long been of interest in the prevention of cardiovascular disease. It's good to recommend eating oily fish, particularly when it replaces food with high saturated fats in the diet. Of the omega-3 fatty acids in fish, two of the best characterized are eicosapentaenoic acid, EPA, and decoxyhexaenoic acid, DHA. These are widely available in fish oil preparations, which you can buy over the counter, and krill oil preparations. And they have a variety of effects, including reducing concentrations of triglycerides. I think some of the benefits of including these compounds in a pharmaceutical preparation are demonstrated by the results of some recent clinical trials, which investigated omega-3 fatty acids for their ability to reduce cardiovascular events in susceptible individuals. There are three fairly recent trials for which I think quantitative data is currently available. The VITAL trial and ASCEND trial showed no benefit of omega-3 fatty acids on cardiovascular events, whereas the REDUCE-IT trial showed a substantial benefit. There are differences in these trials in terms of the populations in the trials and in terms of the exact endpoints used. But an important difference is the composition of the fatty acids. In Vital and Ascend, the patients received a mixture of EPA and DHA, whereas in Reduce It, participants received a much higher dose of EPA and pure EPA. And I think this tells us what we perhaps know already if we've studied drugs, that the efficacy of a compound depends on the composition and the dose. And I think it is hard to get that exactly right from food alone, but we can do that with nutraceuticals. Another example, I think, where nutraceutical approach has been well used is with red yeast rice. This really attractive looking food is a product of yeast grown on white rice. It's an ingredient in Chinese food and medicine. The active ingredient is called monocholine K, although monocholine K is actually molecularly identical to lovastatin. So red yeast rice has statin-like lipid lowering effects. It also sometimes causes statin-like side effects, muscle symptoms, but actually often less than for an equipotent dose of a synthetic statin. But there can be some problems with using red yeast rice as a food for lipid lowering. Of course, there might be batch-to-batch variations in the content of monocholine K, and some batches of red yeast rice have been found to be contaminated with citrulline, a mycotoxin metabolite, which may be nephrotoxic. So one approach to overcome some of these difficulties is a product called Lipid Plus, which is actually a nice product because it's a polypill approach that contains a number of ingredients, including red yeast rice, which are thought to perhaps have some benefit in the context of atherosclerotic cardiovascular disease and hyperlipidemia. And Lipid Plus has been investigated in a clinical trial for 6 months in statin-intolerant patients or patients who'd refused statins. And the lipid lowering caused by this preparation was actually similar to that seen with ezetimibe in a randomized trial, which I think is very interesting. And the International Lipid Expert Panel, in its guidance on nutraceuticals in statin-intolerant patients, gave this product a Class 1 Level A recommendation based on this and other studies. So in conclusion, I think hopefully these examples I've shown you show us that nutraceuticals have the potential to optimize the treatment and prevention of cardiovascular disease. They're not there to replace a healthy diet, and they're not there to replace conventional therapies, but I think they have their place in optimizing these treatment and prevention of disease. The two examples I've given are, I think, good examples of where evidence-based medicine has been applied. Randomized controlled trials have been used in products which have been manufactured according to good manufacturing practice. It's important to notice that for many nutraceuticals, as Professor Banach said earlier, the efficacy and safety is often based on short-term studies with surrogate endpoints. Nutraceuticals are often unlicensed products, so there might be variations in the quantity of the active ingredient between batches. There might be contaminants present. And so I think the future lies in applying the principles of good manufacturing practice and then evidence-based medicine to provide patients with quality and safe products which have a therapeutic efficacy which we can measure and be sure about. So it just remains me to thank you for listening, and particularly to thank Professor Banach for the very kind invitation to speak today, and to thank all my friends in the International Lipid Expert Panel and the Lipid and Blood Pressure Meta-Analysis Collaboration Group, who've done much of the work that's supported this presentation. So thank you.
Thank you very much, Peter, for a beautiful presentation. In fact, I would like to summarize in few points, which is, I believe, very important. You've mentioned and emphasized during your presentation. So, quality of the nutraceuticals we are looking for, and we try to use. So the quality of the production, which is very important, and the quality is at the same level with the lack of contamination of the nutraceuticals during the production, because the beautiful example of citrulline in red yeast rice might cause the adverse effects, in fact, that have been observed. Second thing, I believe it is very important to look for the nutraceuticals with the evidence-based medicine concerning efficacy and safety. But I believe after the presentation of Dan, after Maciej and after Matteo, we will also have some time in order to discuss whether we should expect randomized controlled trials long-term in order to evaluate the real efficacy and the influence of nutraceuticals cardiovascular outcomes. It is the issue of the large debate, in fact, whether it is necessary or not. In fact, something you have only mentioned about the nutri-vigilance, so the observation of the adverse effects after nutraceuticals, similar to, in fact, to those which are observed after pharmacotherapy, so pharmacovigilance. So I believe those issues will be further discussed, but I don't want to delay with the next presentation, because Professor Dan Gaita would be able to say much more about the place of the nutraceuticals in the recent guidelines. So Dan, it is a great pleasure that you are with us, and thank you very much.
Thank you so much, dear Maciej, dear Peter, dear Matteo. I'm very happy to be here with you, dear friends all over the world. It's to be again after, I think that first ILEP webinars were in June. So after 3 months, the things are changing, but our friendship not. And also the debate is wonderful, more than ever, because we have time to share with you about nutraceuticals. And I like this colorful image about lipid profile in patients with dyslipidemia, because at the end is based on the fact that my task today is to speak about the guidelines, especially European and American, of course, amazing ILEP recommendations, and also to put the question, is monotherapy or is it a place for polypills? Even since 2017, in European Heart Network statement, they wrote that for sure dietary factors make the largest contribution to the risk of cardiovascular mortality and cardiovascular dailies at the population level across Europe of all behavioral risk factors. And going further, I like the most this slide because it's helping me to put on the stage how it looks like. Probably it's a kind of simplification or exaggeration, but I think there are a lot of truths behind of this. First of all, this was about coronary heart disease mortality in United States, prevented or postponed in these 2 decades. And what is important that where I wrote nutraceuticals is connected with population strategy somehow, and where I wrote drugs, that means prevention drugs or intervention, is connected with secondary prevention. Because the slides, the original looks like that. It counts half of decreasing mortality due to coronary heart disease, knowing that half of cardiovascular disease mortality is took by coronary heart disease mortality. And for sure in this situation, we did mainly powerful drugs. So speaking about prevention, due to powerful prevention drugs like statins, antithrombotics, ACE inhibitors or sartans are, but also we need a place for these risk factors better. And Peter introduced wonderfully this part and simplify my task, because it's not only reducing cholesterol in the diet, speak about the lipids, but also probably an important place for nutraceuticals. Going further and having these 3 points, the best presented topics are 3. It's coming from the past. Already Peter introduced red yeast rice, and in 2019 ESCAS guidelines, is written that red yeast rice is a fermented pigment, source of fermented pigment, and it's play a role at the statin-like, in a statin-like mechanism. And of course, it's a long-term safety, regular consumption, and the effect is similar with the statins as already presented. And why to do all these things? Because it's the only available randomized control trial in patients with ASCVD, this component, and may be considered in people with elevated plasma cholesterol concentration. But of course, it's a clear need for better regulation of this drug. So we have to use this in a special situation. And this is already in the guideline, in EAS lipid guideline. So red yeast rice, and this is the guideline, and it's written as nutraceutical, magnitude of the effects with 2+, level of evidence A, and of course, highlighting that is the only available randomized controlled trial in patients with ASCVD. We have data in 2020 for Misano, particular monocholine K, MONC, and in association with berberine to reduce LDL cholesterol. And also in the conclusion of this article is can boost its efficacy, yes, speaking about improving lipid profile with lipid-lowering diet. And of course, we have here numbers and proofs. And here, an interesting chart reducing total cholesterol, reducing LDL cholesterol with an important percentage, and reducing triglycerides. And with yellow is monocholine K alone, and there are others in this study. And in this wonderful international lipid expert panel article is connected with food supplements derived from this rice, contain concentration of monocolines up to 1.9%. Of course, again, stated that is structurally identical with lovastatin, which is a statin with quite low power, but enough to influence, because this is monocholine K and lovastatin profile and availability can be different, and reduce LDL cholesterol at the average of 1 millimole compared with placebo. That means is in line with moderate intensity statins. That means 40 milligrams of pravastatin, 10 of simvastatin, and 20 of lovastatin, wonderfully presented here. Of course, we can notice a small increase in HDL cholesterol, and of course, in a decrease, 1/4 millimole of triglycerides. And the dosage is varying, 1,200 milligram per day to 4,800 milligram per day, containing 4.8 to 24 milligram of monocholine K. Of course, we are looking as doctors for safety, but we have safety because the incidence of liver abnormalities and kidney injury was between 0 to 5% in the studies. And of course, we can have muscular symptoms, but this incidence is very low compared with control groups. So the safety profile is similar to of low dose of statin. And also there are proofs that improves endothelial function in humans, and this product is recommended because of its effect of LDL cholesterol reduction in patients with moderately elevated cholesterol, especially in primary prevention. But as you knew already, it's a place for those with statin intolerance. So this is safety first, and this is class level 1A with all what I introduce you in this chart. We have ILEP recommendation, and in this, the role of nutraceuticals in statin intolerant patients, published in JACC. We have this state that is an alternative to statin therapy in patients with mild to moderate hypercholesterolemia, considered to be, particularly those considered to be statin intolerant, and suggests that is well tolerated, safe, and effective for cardiovascular disease primary prevention. And again, about the dosage, 4 to 12 weeks in subjects with dyslipidemia, decrease in LDL cholesterol with an important around 1 millimole decrease. And this is the chart, for sure you know, it's also a place for a combination. That's why we started to tell about could be a part of combination therapy, and also is written here in this recommendation. Okay, we are human, so there were some concerns. There were some concerns in 2018 about the idea that probably monocholine is not a perfect product, but of course, we have a rebuttal, and this came also from our group with Maciej here, and in this group with a lot of other friends in this part, highlighted that in conclusion, lipid-lowering dietary supplement seems to be overall tolerable and safe in large population of moderately hypercholesterolemic subjects. That means was after that, and it's another proof that we can go further. Only one slide about American guidelines, and they are telling in hypercholesterolemia again about red yeast rice. Speaking about monotherapy or polypills, combination nutraceuticals with different lipid-lowering activities. It's a rationale for this. It's an alternative to drug treatment for patients in primary cardiovascular prevention with mildly elevated LDL cholesterol, and in some statin intolerant patients. And of course, this product is a part of reducing the residual cardiovascular risk. Instead of conclusion, I put this article highlighted that monocholine K has a statin-like mechanism, lowering total cholesterol and LDL cholesterol. Of course, some reduction also on triglycerides and a small increase in HDL cholesterol. And it's only one concern about the quality of these products, but for sure the EU regulation is doing well in this direction. So ending with, in the same manner I started, I try to reduce in my patient the coronary heart disease risk or cardiovascular risk. And I'm using mainly drugs, powerful drugs, prevention drugs in those already in secondary prevention or in high-risk population, but helping them with nutraceuticals for the rest. And monocholine K, it's one of the important products. And highlighting also that doctors can learn something from wellness. It's clear that some people are looking for healers, so we must find, okay, so these products are not only healers, we have already proofs, scientific proofs, so we can go further to the last point. I ended in June with this coronarian coming from Corona, and I put the same question about cholesterol. Should we care about it in this pandemic?
Thank you, Dan. We have had some problems with connections, but hopefully most of us were able to hear the most important issues, especially at the beginning, at the first half of the lecture. You know it very well that the good thing, taking into account the nutraceuticals, is that it is not our opinion that they might be very helpful, because we might see that they are in the guidelines. Obviously, one important thing I would like to strongly emphasize, that nutraceuticals cannot replace pharmacotherapy, and all should remember about it. But on the other hand, they might be very useful in order to optimize the therapy and to be on the target with our patients. And Dan beautifully presented all the guidelines and all the examples of the guidelines and what kind of nutraceuticals are put into the guidelines: radius rice, omega-3 acid, polycosanol, berberine, and few others. And I believe that during my presentation and the real life case reports by my Matteo, we would be able to bring you to the much more detailed information. So if you don't mind, I will try to with my presentation, if I may ask. My topic is to discuss with you how important is early intervention to reduce LDL cholesterol in patients with low to moderate risk. I don't want to focus now on the very high risk patients and extremely high risk patients, in which I believe that the role of nutraceuticals is much lower, but especially I would like to put your attention to those groups of patients with low to moderate risk that sometimes are very debatable, because, for example, doctors and physicians do not want to use drugs, or it is too early to use drugs, or to use very low doses of the drugs. These doses might be not effective, and what to do, and whether the diet or maybe nutraceuticals might be simply useful. I believe it is a very important slide, because it is from our cross-sectional study with superb leadership by Koshray from Imperial College of London, 18 countries, almost 6,000 patients. And as you can see, that most of the patients in primary and secondary prevention were patients at low to moderate risk. So we have a great data in order to see how the targets based on the recommendation of 2016 and 2019 European guidelines are met in this group of patients. As you can see in this slide, in low and moderate risk patients, when we compare 2016 and 2019 guidelines, especially, there is still a lot of patients without being on the goal of the therapy. And when we lower the targets in 2019 guidelines, there was still much more patients in moderate risk. For them, the new threshold, LDL threshold, is less than 100, and about 40% of patients might be not on the target of our LDL cholesterol. So we need to do our best in order to improve our treatment. We need to do our best in order to give the doctors the tools how to do it effectively. Why we are talking about this? Because most of the trials, most of the cohort studies, when we discuss, for example, the issue of the lipid-lowering therapy, we focus on the high-risk, very high, extremely high-risk patients. But if we would like to answer the question whether it is necessary also to target LDL cholesterol, to reduce LDL cholesterol also in those patients with low to moderate risk, I believe that you agree with me that we have a number of different trials in both from prospective cohort studies, randomized control trials, as well as Mendelian randomization studies that confirm that if we are effective in the reduction of the LDL cholesterol for years, so for example, when we started that in the time when we can see that the LDL cholesterol is persistently elevated, and then we continue the reduction of the LDL cholesterol, and our patients are on the target, we might reduce cardiovascular risk by 20-25%, which is associated with 5 years of LDL reduction therapy. And when we continue it, we might reduce LDL cholesterol level and reduce LDL cholesterol level by even 40 years. We might reduce cardiovascular risk by even 50-55%. So early intervention is critical for most of our patients, not only those being on the at the very high and high cardiovascular risk. Why it is important? Why we have been talking about it? Because it is a beautiful paper we presented with a group of experts of the International Lipid Expert Panel, European Atherosclerosis Society, led by me and Alberico Catapano, Professor Alberico Catapano, and we in this paper, I believe one of the most important issues associated to the fact that we've said, if we try our best with using all the methods, including nutraceuticals, so natural product approach, and we reduce LDL cholesterol level in the population, we might have the population approach to reduce cardiovascular risk. So in other words, we should do our best in order to reduce LDL cholesterol in our population, because in the consequence we will be effective in the reduction of the cardiovascular risk irrespective on the baseline cardiovascular risk of our patients. Okay, please have a look at the most recent guidelines. There are a lot of changes in comparison to those from 2016, because especially if we look at the patients at the low risk, below 1%, in the 2016 guidelines, for those patients being between the 115 and 190, there was no recommendation for pharmacotherapy. So there was many discussions after 2016. Okay, if we have patients with the persistent elevation of LDL cholesterol over 140, 150, shouldn't we consider low doses of statins, maybe nutraceuticals, maybe combination of statins with nutraceuticals, simply in order to be on the target, in order to reduce LDL cholesterol level? If we are not effective with diet, with lifestyle changes, and there was obviously many different attempts at response at this question, but in the end, in the new guidelines, you have a very clear recommendation that we need obviously suggest lifestyle intervention, but we might consider adding drug. But how to do it effectively? It is the paper. The funny thing is that it has been accepted today for BMC medicine, so it is probably the first presentation of the accepted paper by Peter Penson and Matteo Pirro. Those experts you might see during this ILEP second edition ILEP webinar. And this is a very step-by-step approach how to be effective in low-risk patients with elevated, persistently elevated LDL cholesterol level. We simply, discussing different cutoff points, we decided at least for over 140. Why it is important? Because we know it very well that for those over 140, any lifestyle changes will not be effective in order to be on the target below 115 for those patients. So obviously we might start for those patients being at 140, 150 with the lifestyle intervention, different lifestyle interventions, including well-balanced diet, especially diet with low levels of cholesterol, especially without saturated fat, but obviously with the high amount of the PUFAs and MUFAs, especially PUFAs, because I believe that polyunsaturated fats are much more important in our diet. Obviously, with regular exercises, with reduction of the excessive body weight and smoking cessation, altogether, we might expect that it might be associated with the reduction of LDL cholesterol level by 20-25%. So, if we have an optimal adherence to this lifestyle intervention, we might have our patients being on the goal of the therapy, so we continue lifestyle intervention. Obviously, it is a quite rare situation. I believe it might refer to 20-25%. I believe even less than 20% of our patients. So each fifth patient might be adherent to this kind of lifestyle intervention. But for those who are not adherent, and especially for those who are with the pure adherence to lifestyle interventions, I believe we should start as quickly as possible with a low-dose statin, and then we might consider ezetimibe and nutraceuticals, especially in those when low-dose statin and ezetimibe are not effective and those patients are still over 115, so are over the target, which is dedicated for low-risk patients. So I believe it is a very clear situation, very clear feature how to do it effectively in our low-risk patients with a very high level of LDL cholesterol. Okay, let's a little bit focus on nutraceuticals, because I believe it is critically important that we, in fact, not only know how to produce, not only know what kind of results we expect, taking into account the efficacy and safety, but we know also about the mechanism of action, because some of them might work in the might affect the metabolism of cholesterol in liver, very similar, for example, to statins. Some of them might be outside the liver. They might act as inhibitors of intestinal cholesterol absorption or enhancers of cholesterol extraction. So the way of the properties might be very similar to ezetimibe, and some of them might be very typical to omega-3 acids. So it is something that Peter and Dan has already mentioned. Omega-3 acid, now it is a very hot topic issue, in fact. So if we know how they work, in our recommendation of the International Lipid Expert Panel recommendation 2016 and 2017, we simply put those nutraceuticals with suitable evidence-based medicine into the class and level of recommendation. As you can see, when we look at the lipid-lowering therapy, radius rise is 1A. For example, garlic is 2AA. For example, soluble fibers are 2AA, and so, for example, plant sterols and stanols are 2AA. So it's a very high level of recommendation. But in fact, they work in a completely different way. And the level of reduction of LDL cholesterol is also different, because for radius rise, which consists of monocholine K, and which is not natural lovastatin, even at the low dose of 3 to 10 milligrams. However, taking into account the recent EFSA recommendation, we should be closer to 3 milligrams. We might expect even 15 to 25% reduction of LDL cholesterol. For garlic, I believe it is much less, but on the other hand, garlic might reduce triglycerides, might be hepatoprotective, might reduce blood pressure, and for plant sterols and stanols, it is the same, because it is quite low reduction of LDL cholesterol, usually up to 10%, but it might also have effect of the inflammatory markers. So I usually say that for nutraceuticals, we might expect so-called pleiotropic effects, a little bit similar to statins, because they not only work for lipid lowering parameters, but they might work on also for glucose, for blood pressure, for inflammation, for oxidative stress, for vascular stiffness, for endothelial functions. So I believe it is a very great benefit of nutraceuticals, because their properties might be very, very wide, and that is why we might expect very different and very very beneficial effects of nutraceuticals. It is another example. So, for example, berberine, very effective in the reduction of the LDL cholesterol by 15-20%. And, for example, green tea, which might be associated with the reduction, for example, of blood pressure. And PUFAs, as I've mentioned, especially associated with the reduction of triglycerides. But it is, besides radius rise, PUFAs are those nutraceuticals for which we have a cardiovascular outcomes data. Please have a look at our network meta-analysis we did and presented for the first time at American Heart Association Congress. In network meta-analysis, it is a kind of prioritization of the nutraceuticals, starting from those with the higher effect, for example, of the LDL cholesterol, going down with the less effect of the LDL cholesterol. So as you can see, polycosanols and radius rise and berberine are those nutraceuticals with the highest effects on the reduction of the LDL cholesterol. And as you remember the slide from Dan Gaita on the American guidelines, in fact, it is completely in line with the recommendation of the American guidelines, because polycosanol, radius rise, and berberine have been mentioned in the American guidelines. What about the triglycerides? Please have a look. Berberine again, radius rise, polycosanols, and artichoke might be effective in the reduction of the triglycerides. So, on the other hand, we might in fact expect that for some of the nutraceuticals, they might be not only effective for the hypercholesterolemia, but they might be also effective on the, for example, atherogenic dyslipidemia in patients with diabetes, in patients with obesity, in patients with metabolic syndrome. So it is another benefit of using nutraceuticals. And as I've mentioned, radius rise and PUFAs are the only nutraceuticals for which we have a cardiovascular outcomes trial. And I will be very, very happy to discuss with you whether we should expect, in fact, cardiovascular outcomes trial for nutraceuticals. But please have a look for that for radius rise, which was used for 4.5 years at the dose of up to 3.2 milligrams, we observed very significant reduction of the cardiovascular outcomes. What about the statin intolerance? Both Peter and Dan mentioned that on the role of nutraceuticals in statin intolerance, and this is something we would like to completely change the current recommendation of the European Atherosclerosis Society and European Society of Cardiology guidelines, because you probably mentioned that if we have symptomatic patients with statin-associated muscle symptoms, with the increase of creatine kinase, there is a recommendation to discontinue statin therapy. And we would like to say, okay, if you would like to discontinue, but on the other hand, if you have a patient with high and very high cardiovascular risk, please immediately start with the lipid-lowering therapy with ezetimibe and nutraceuticals, because then we might expect still reduction of the LDL cholesterol level, especially in patients with complete statin intolerance, because in partial statin intolerance we might still use low levels of statins, low doses of statins, on alternative day statin therapy. And do we have a recommendation? It is again, please have a look at our slide. Our recommendation we published in Journal of American College of Cardiology, very clear recommendation which nutraceuticals with lipid-lowering properties might be used as an addition to the therapy of patients with statin intolerance, patients who are very, very difficult to treat, because those patients without treatment, without adherent, are at the risk, very high risk of the recurrent cardiovascular events, the risk of the cardiovascular events. Do we have a data? Because, for example, there is a large discussion, should we use natural lovastatin, so monocolin K, if we have a patient with statin intolerance? And we have a lot of data that confirm that when we, due to the fact that it is a not potent statin, which is lovastatin, at very low dose, usually at the dose of 3 milligrams, there is no issue of the adverse effects. Obviously, we should have it in mind, because it is natural lovastatin, but it is not an issue. We shouldn't think that it might be associated with adverse effects, because due to the based on the data I've seen, taking into account nutri-vigilance, I can promise you that it is a very, very rare situation that we might observe the adverse events after monocolin K at very small dose. Okay. Especially we confirm in our meta-analysis that also Dan mentioned that using radius rise is not associated with the increase of musculoskeletal disorders, and irrespective of the dose, and as you can see also in patients with statin intolerance, what is more, it might be even associated with the reduction of the serious adverse events, and especially non-musculoskeletal disorders like gastrointestinal and many others. Okay. I've mentioned at the very beginning whether it is possible to consider nutraceuticals in severe hypercholesterolemia, such FH patients. Please have a look at the Odyssey Price data. These are real-life data that showed that, okay, using triple therapy, because ezetimibe was used in about 70% of patients, we might be very effective in the achieving of the goals, especially these were still goals based on the 2016 guidelines. But as you can see, even it was 62%, but still they were about 30% of patients without being on the goal. So it is something that we should have in mind that, okay, if we have a triple therapy without being on the goal, maybe we should consider another lipid-lowering therapy, which is natural products, which is very well tolerated, that might help us in order to be closer to the goals. Especially that in the registry, it is a beautiful registry by Ulrich Laubsev and his group from Germany. We know it very well that even in patients with using triple therapy with PCSK9 inhibitors, especially in patients with FH, we know it very well that when we start with a very high level of LDL cholesterol baseline, we might not be effective in order to be on the goal of the therapy. And that is why another agent, such as nutraceuticals with confirmed lipid-lowering therapies, might be very, very useful. And do we have a data? Beautiful paper by Claudia Stefanuti for patients with the confirmed statin intolerance, in which radius rise was used, and as you can see, LDL reduction by 31% in patients with statin intolerance. So in statin intolerance and FH, so patients being at least high and very high cardiovascular risk. So nutraceuticals, yes, might be considered in patients with FH. And it is my last slide because it is a quite new approach how to treat patients being at a very high risk and patients with FH. We should always have in mind the efficacy of lipid-lowering drugs, because if we have a patient with FH with the baseline cholesterol 300, and we know it very well that using the triple therapy, statin, intensive statin, ezetimibe, and PCSK9 inhibitors, we might reduce LDL cholesterol by 85%. For optimal responder, we might not be on the target below 55 and especially below 40 if it is extremely high risk patients. So that is why at the very beginning we should in fact plan therapy, and we should start with the combination therapy in fact at the time of the diagnosis. We shouldn't wait any longer, because if we wait, we increase the risk of cardiovascular outcomes. Thank you very much. I believe the discussion will be after the last slide and after the last presentation. And I'm knowing Matteo, who is a great expert on nutraceuticals, in fact, with, I believe, much higher experience than mine. So I believe that he has a great examples of beautiful cases. So Matteo, the floor is yours. I'm looking forward to seeing your presentation. Thank you.
Hey, thank you very much, Maciej. So, can you hear me? Yeah, I hope so. Good. So let's start with the case, the clinical case. It is a clinical case that regard a subject, a 48-year-old man with a family history for hypercholesterolemia. His mother, 73 years old, with an hypercholesterolemia, treated with simvastatin 20 milligrams per day. So with an actual LDL cholesterol level of 160 milligram per cent. An history, a familial history of ischemic stroke, not an early stroke, but a stroke in his father at 79 years old. 2 healthy brothers, 1 sister with hypercholesterolemia, moderate hypercholesterolemia, and 2 healthy sons. The clinical history of this subject is a recent diagnosis of hypertension that the patient is still not treating with a drug, but we will treat, as you can see in the following slides. The subject is a non-smoker. As I told you, a blood pressure increase, 144/90 millimeters per mercury, and he is an overweight subject with a BMI of 28 and increased waist circumference, and there is no sign, no evidence of those clinical signs of familial hypercholesterolemia like St. Thomas or corneal arch. So this is a subject that presents to our visit with 2 lipid profiles. The first lipid profiles regards 1 year before the current visit, where he appears to have a mixed hyperlipidemia with an increase in plasma triglycerides level to 293 milligram per cent, and an LDL cholesterol elevation with 153 milligram per cent, HDL cholesterol in the normal limits, and fasting plasma glucose of normal 92 milligram per cent. So he followed some kind of therapeutic lifestyle changes during the last years that allowed him to reduce and normalize his plasma triglyceride levels up to 145, but not his LDL cholesterol level that are still increased above 140 milligram per cent, so 148 milligram per cent with normal HDL, normal fasting plasma glucose. So what we have to do when we have a patient, a subject like this, primary prevention, just 1 risk factor in addition to a moderate hypercholesterolemia. The first thing that we have to do is to try to make an etiological diagnosis. And so to do this, we should have in mind what are the more frequent causes of these lipidemias, the secondary causes of these lipidemias, and the primitive forms of this lipidemia. So this subject didn't have hypothyroidism, was not affected by paraproteinemia, was not affected by any disease that may contribute to increase his plasma LDL cholesterol levels. We know he was an overweight subject with a moderate increase in plasma LDL cholesterol levels. Obviously, if you consider that the most frequent and severe form of genetic dyslipidemias, he doesn't have a familial hypercholesterolemia, a familial combined hypercholesterolemia, and the other forms like this beta lipolipoproteinemia, familial hypertriglyceridemia. In particular, what we can do here is to measure, is to calculate his Dutch lipid score, and you can see from his plasma cholesterol levels below 4 millimole per liter. So it was with an LDL of 148. By considering the absence of clinical signs of familial hypercholesterolemia, no xanthoma, no arcus cornealis, by considering his family history of hypercholesterolemia, just 1 point, but no history, personal, familial history for cardiovascular disease. So this subject is very unlikely to have a familial hypercholesterolemia, a score of just 1, so below 3. So we can be sure that he has not a familial hypercholesterolemia. So after doing this step, so to try to make an etiological diagnosis that this patient may be considered a polygenic hypercholesterolemia, we have to calculate, we have to estimate the cardiovascular risk of this subject by considering, by searching for the cardiovascular risk factor to which this patient, this subject, is affected. So as I told you, he's a male above 45 years old, and this is a risk factor. He's a hypertensive subject without any hypertensive medication. He has an increase, a moderate increase in plasma LDL cholesterol without any other cardiovascular risk factors. So another thing that we have to do and to consider is whether the subject has cardiovascular risk equivalence. So equivalence, clinical equivalence of high cardiovascular risk. What we are sure is that this patient, this subject do not have a very high level of a single risk factor. It doesn't have multiple risk factor, is not FH, is not diabetic, his anamnesis is negative for CKD, CHD, CVD, PAD, and by doing a carotid ultrasound, it doesn't have atherosclerotic evidence of plaques at the carotid district. So it doesn't have any cardiovascular risk equivalence. So what we have to do now in this kind of subject with a moderate LDL cholesterol elevation, with an additional cardiovascular risk factor and hypertension without a cardiovascular risk equivalence, is to try to estimate the 10-year cardiovascular risk. So the most useful, the most used chart in Europe for calculating, for estimating the risk is the EAS risk score. So if we look at how the characteristic of our subject, man, non-smoker, with an elevation of plasma LDL cholesterol and particularly of total cholesterol, 6 millimole per liter, 48 years old, with a blood pressure of 144 for systolic blood pressure, you can see that the estimated risk of this subject may apply up to 0 up to 1%. So a low to moderate risk subject. So in this kind of subject with the low risk, there is a very low consciousness of the importance of cholesterol elevation. So what we can do in this kind of subject is to try to improve the consciousness of this patient, of this subject, to the risk of that is associated with his plasma LDL cholesterol level. So what we can do is to calculate and to use additional tools to estimate the risk. One tool is represented by the relative risk estimation. In this kind of subject, young subject of 40, 45, 48 years old, we can calculate the relative risk that in this case is twice the risk of a subject with normal cholesterol, normal blood pressure, non-smoking subject in a low risk region of Europe. So we can increase the consciousness of our patient by saying him that he has a double risk to have a cardiovascular events in the next 10 years as compared to a normal subject without any cardiovascular risk factor. Another way to increase the consciousness on our patient is to calculate and to estimate the cardiovascular risk age, that in this case is 55 as compared to the real anagraphical age of this subject, that is 48. So we have several tools to improve the consciousness on cholesterol, on the importance of cholesterol in causing cardiovascular events. Another tool is represented by the lifetime cardiovascular risk. So if we calculate the cardiovascular risk, the lifetime cardiovascular risk in this subject, you can see it is high, is almost 50%. So just to underline, it is a low-risk subject with a moderate risk, lifetime cardiovascular risk, to develop in his life an event. So after doing this, after defining after estimating the cardiovascular risk, after knowing the lipid profile and the burden of cardiovascular risk factor of this subject, what we have to do is try to define the most appropriate target for this subject. And the way that we have can do is by considering the objectives of treatment goals that we all know today. For a low-risk subject is below 116. For a moderate risk subject is below 100 mg/cent. So our subject is in between a low to moderate risk. So what we can consider is to try to choose the therapy, the lipid-lowering therapy, in order to reach the treatment goals defined according to the low risk of this subject. So by coming back to the fasting lipid profile of this subject in a subject with a low to moderate risk, what we have to do starting from 148 mg/cent is try to reach the goal of a low risk patient below 116 and trying to approach to 100 mg/cent. In other words, we have to try to reach at least a 25% reduction in plasma LDL cholesterol. So what we did for reaching this target and what we are the recommendation from the guidelines, as Professor Gaita already told, and Maciej too, and Peter already remember and recall it to us, is that in a low risk subject and in a moderate risk subject, the first step, if we have an increase of LDL cholesterol between 116 and below 190, the first step is in the primary prevention of a low to moderate risk, is a lifestyle intervention that may be added eventually also to a drug therapy in the case that we do not reach by a lifestyle intervention the recommended goals. But what is important to see, what is the efficacy of a lifestyle, what is of a therapeutic lifestyle changes on plasma LDL cholesterol. This is a meta-analysis showing the net effect of reducing total fat, saturated fat, of reducing trans fatty acid and increasing dietary fiber, fruit, vegetables on plasma LDL cholesterol. What you can see there is in the long term, the net effect on plasma LDL cholesterol is quite weak, is quite poor, just a 6 mg/dL reduction in plasma LDL cholesterol. So what we know today is that by using exclusively only a therapeutic lifestyle changes, maybe we will not be able to reach the recommended goal because the effects, the net effect on the plasma LDL cholesterol of this subject is just really small, just 5-10 mg/cent. So, but what the guidelines says about the lifestyle intervention, what the guidelines includes within the lifestyle intervention to reduce total cholesterol and LDL cholesterol. As already recalled by the previous speaker, we have additional tools in order to reduce conservatively plasma LDL cholesterol in this subject. So we already said about reducing trans fatty acid, reducing total fat, saturated fat, increasing physical activity, but we have also additional tools. And one of these tools is represented by nutraceuticals, and in particular, those nutraceutical containing red yeast rice. Here we have a panel in which we resumed the net effect of several nutraceutical combinations that have a common soil. The common soil is represented by the fact that all these combinations of nutraceuticals always contain red yeast rice. And what you can see for all these nutraceutical combinations, and in particular for the combination of the red yeast rice with berberine and polycosonols, the vast majority of studies, what we can expect from using this kind of nutraceutical combination is a 20-25% reduction in plasma LDL cholesterol that we can add to the effects of therapeutic lifestyle changes that's reducing even more our plasma cholesterol levels. So that's what we did in this kind of subject. So a starting lipid profile with a normal triglyceride level and a moderate increase in plasma LDL cholesterol above 140 milligram percent. So we started a blood pressure lowering with telmisartan, and also we prescribed a therapeutic lifestyle change, as those I already presented, along with a nutraceutical combination of a low dose of red yeast rice, 3 milligrams per day, along with berberine and polycosanol. So what we obtained after 4 months in this subject is a reduction in body weight, a reduction in BMI, also a significant reduction in the target was reached for blood pressure levels, but above all, we obtained a normalization of plasma triglycerides and also a significant 27% decrease in plasma LDL cholesterol, thus reaching 108 milligram percent. So what we can say is that in this kind of subject, this is an emblematic example of low-risk subject with LDL above 140, as those presented by Maciej in the flow chart for the treatment of low-risk subject. So we have an additional opportunity, along with therapeutic lifestyle changes, along with eventually drugs, we have another opportunity that is represented by nutraceuticals, and specifically and more in-depth nutraceutical containing red yeast rice. In that case, the combination of red yeast rice plus berberine and polycosanol allowed us to reach the target to improve the compliance in the long term. It should be conservative, should be maintained in the long term if you want to obtain also probably an effect also on the cardiovascular risk endpoint of this subject and of this kind of population. Thank you for your attention.
Thank you very much, Matteo. As I thought that it will be a beautiful case, so thank you very much. It is a step-by-step approach how to be effective in patients at low risk. And especially I would like to put your attention about the one critical issue that we often forget, because when we have a patient with lipid disorders, we usually think how to treat it effectively, to be safe with the treatment, to look for the statin intolerance and so on. But very often we forget to think about the secondary dyslipidemia. So in order to exclude all those conditions and risk factors that might cause lipid disorders without, and in fact, optimization of the, for example, of the thyroid function and so on might be associated with the improvement of the lipid profile. So it is, please always remember about the secondary cases of this dyslipidemia, including obviously, for example, drug-related cases of the dyslipidemia. I remember one of my patients from several days ago, in the time of COVID-19. It was a female she was very afraid of being infected with COVID, and that is why she decided to take one of the antiviral drug as a kind of prevention. And you know it very well that antiviral drugs might also cause hyperlipidemia. And when we measure LDL cholesterol as a kind of coincidence, because it was not our plan in order to look for the LDL cholesterol, because previous measurement was optimal. It was 184. So she was very clear to 190. So, and obviously without any treatment, we simply stop antiviral drugs, and after 2 weeks, the level of LDL cholesterol was completely normal. So please remember about antiviral, antiretroviral, and other drugs that might, steroids and so on, that might also be associated with the lipid disorders. One, I believe, critical issue is, because I mentioned at the very beginning, because we have the first questions, and if I believe it is a beautiful moment for those who are watching us now to ask questions and to raise your concerns about the nutraceuticals. But one issue is that I don't know if it is your perspective, that when patients enters your room and usually say, okay, doctor, I am at the low risk, on the moderate risk. Maybe it is not suitable for me to start with statin therapy, because statin therapy might be associated with the liver injury, for example, which is not the truth, obviously, but it is always the kind of way of thinking of our patients. Maybe we should use nutraceuticals. And in fact, I've been in the pharmacy, and I was advised to use. And here is a list of different nutraceuticals that I usually advertised in the pharmacy. So, what is your experience, really practical experience, with what kind of nutraceuticals you usually recommended to those patients who might be recommended? Because my second questions will be, what patients might benefit the most? So, what patients we should recommend or might consider recommending nutraceuticals? So maybe Matteo, what is your personal experience of using nutraceuticals? Which one, in your opinion, are the best concerning the lipid-lowering therapy? Yes, please.
Yeah, thank you very much, Maciej. You puntualized very important points. So the first thing, which kind of nutraceutical I could advise, or I advise in my clinical practice? Generally, I tend to use low-dose nutraceutical combination. There is a reason, a very clear reason. We know that we learn it from drugs. That if we learned it from hypertension, drugs for hypertension, drugs for diabetes. If we use low-dose combination of drugs, we may increase the effectiveness of the drug, and we can reduce the side effects of the drugs. Exactly the same will happen with the nutraceutical combination. If we combine low doses of nutraceutical with different mechanism of actions, let's see, for example, monocholine K that acts on HMG-CoA reductase, berberine that acts on the stabilization of the LDL receptor on PCSK9. If we use ideal combination with the complementary effects, we can increase the effectiveness in reducing cholesterol. We can obtain also some effects on additional parameters. I think, for example, for berberine is able to reduce cholesterol, but also to act on an AMPK that's reducing a little bit triglycerides, a little bit glycemia, and it is a wanted effect. This is a very good effect that we can obtain in order to enlarge the effectiveness of our combination. In addition, we can obtain also less side effects, because we have to think an important point that even nutraceutical at high doses may have side effects. Monocholine K at very high doses may have statin-like effects. Berberine at very high doses may cause dyspepsia, but also fibers at higher doses may cause constipation. So using low doses may be a useful combination in order to improve the ratio, the benefit-risk ratio in a low-risk population that in a very huge population. So we have to search for this kind of characteristics, I think.
Wonderful. Thank you very much. Peter, Dan, do you want to add something to this question, to your personal opinion, to personal experience?
Yes, thank you. Very interesting discussion. The majority of my patients were very severe. So those who had already heart attacks, those who had revascularization. So it's necessarily to make the LDL half at least. So it's not a discussion about another option, but I'm accepting more and more this type of approach when I have, for example, a young fellow with subclinical atherosclerosis, identifying a carotid plaque in a 40 years old male, and discussing that probably in the future we have to change not only lifestyle, but also to decrease LDL cholesterol, because the problem is not why I'm having a carotid plaque, is the fact that having a carotid plaque that is a risk in the future, not demonstrated entirely that decreasing half LDL cholesterol, this plaque will not increase. So in this special group of patients, I'm accepting at the beginning not to be so abrupt in prescribing a statin, to change lifestyle, to have monocholine K, and of course, to check regularly about the risk. So in secondary prevention, very high-risk patient, I am in favor of statins. So I have very few patients with statin intolerance, but I'm more and more sensitive in accepting these type of things because we're identifying more and more subclinical atherosclerosis. Thank you.
Okay, Peter, maybe you might try to summarize this part of the discussion. What is your perspective or opinion? What kind of patients might benefit the most from nutraceuticals? Because we've already said a lot on it, but maybe a kind of such a summary, few sentences to the audience might be very useful in order to remember, to have a clear message on it.
I think I should probably point out I don't have a patient-facing role, so unlike you as my esteemed colleagues, I'm not seeing these individuals day on day, but I think my perspective from my interest in evidence-based medicine is that we clearly always want to use the most evidence products that we can, and those are often directed by guidelines, and there will be patients who aren't eligible for statins because they're at low risk. But as Matteo's pointed out, often risk is calculated on a 10-year basis, when really we're looking at a disease with a lifetime course. So I think probably people at low risk, in a 10-year risk, but who have perhaps one elevated risk factor related to lipids might really benefit from some of these products, and possibly people at higher risk who might not be eligible for some of the newer treatments, such as PCSK9 inhibitors. Maybe if they can't get hold of those and they're not reaching targets on statin therapy, that might be an option to consider. I think one final thing I'd probably think about, and again from my evidence-based medicine perspective, is that we probably want to think in terms of recommending specific products of which we can be sure of the quality and which have been investigated in trials, rather than perhaps recommending particular ingredients or particular ingredients from particular foods. If we can recommend a named product that we know has been made to a good standard, then I think that's important too.
Thank you very much. I would like to get back a little bit to the Matteo and his information on the safety, because most of our patients believe that nutraceuticals as a natural products are complete safe, right? And there's no issue about no safety concerns. But we know it very well that, for example, omega-3 acid might be associated with the atrial fibrillation increase, that there are some concerns concerning the genetic aspects, especially for phytosterols, especially when we have a predisposition to ABCG5 gene and mutation and so like this. So we know it very well that after radius rise, obviously we might discuss it, what is the real prevalence with the low dose of monocholine, but on the other hand, it's natural lovastatin, and we should have in mind that it might be associated with the muscle symptoms, and we have a group of patients with especially, for example, genetic predisposition that might be at the risk of statin intolerance. So I believe you all agree with me that nutrivigilance, so the observation and monitoring of the nutraceuticals, concerning taking into account his safety profile, is important. Matteo, what do you think about it? Do you agree with me?
I agree absolutely with you. Nutravigilance it comes when the nutraceutical is already on the market. So we don't have to stop to observe, to check whether our patients, our subjects may have some effects, some side effects. But I think that we should also integrate nutravigilance, that is a post-marketing phenomenon, also with the absolute assurance that the quality of the product, of the production, and also of all the steps leading to the producers to sell the product. Yeah. You know that most monocholine K is produced. There is is produced almost exclusively in China. So we cannot, Italy, no place in the world may produce monocholine K other than China. So what is important for an importer, for a foreign producer, for nutraceuticals that contain monocholine K, is that the product that is bought in China should be sure, absolutely sure. So quality of nutravigilance, quality of import, quality of production is the essential part to obtain sure products and products without side effects. That's the example of a citrulline is clear. If we have products containing monocholine K that also contain citrulline, we will have side effects. But Europe say that all the products containing monocholine K must have less than 100 microgram per kilogram of citrulline. And there are products in Europe that contain less than 2. So these are sure products. So
and you agree with me that in fact it was the reason that the EFSA scientific opinion paper was in fact based on those cases in which we might probably observe the citrulline contamination, and that is why the adverse effects were observed. Especially it was about 30 cases only, and based on the 30 cases, EFSA has decided to make a recommendation that there is no dose of monocholine K that might be safe. We have another questions. I believe the first one is very tricky one, because we usually discussing, and probably in the second webinar, which will be on the 1st of October, will be maybe dedicated to high and very high risk patients. But the question is from Beata. Good evening. Question: is there a place for nutraceuticals in secondary prevention? So I have my own opinion, but I am the moderator here, so I would like to first hear. Dan do not have large experience, have already mentioned, with nutraceuticals in the secondary prevention. But then, Dan, can you imagine the situation if you have a patient, and maybe not after acute coronary syndrome, but maybe with established coronary heart disease, so in the secondary prevention, that nutraceuticals might be useful?
Yes. Especially in those with statin intolerance. Mm-hmm. So I have to clearly identify this group of patients. So it's an amazing help to reduce with 1 millimole, be done by nutraceuticals. This is my opinion. Thanks.
So one thing I would like to emphasize strongly, so statin intolerance for sure, because I strongly believe that when we have a patient, especially being on secondary prevention at the very high risk, when we have a symptomatic statin intolerance with the increase in CKA, and we decide to discontinue statin therapy, and you remember that we need to wait from 2 to 6 weeks in order to have a re-challenge with statins. You know it very well that there is something which is called LDL visit-to-visit variability, and this is strongly associated with the increase of the cardiovascular outcomes. So I believe that when we stop statin therapy, we should immediately start with ezetimibe and nutraceuticals. And Matteo has already mentioned, and we have papers and data from Giuseppe Rosano group trials, when polypills, in fact, a fixed combination with statin nutraceuticals, with radius rise, it was Armolipid Plus and ezetimibe, was associated with the reduction of the LDL cholesterol by 40%. So it is a kind of moderate potency of statin therapy. So I believe it is critically important. But do you think, what is your opinion? If we have a patient with stable coronary heart disease, and these patients obviously need to be below 55 because it is a recommendation based on the recent guidelines. And when we use the intensive statin therapy and we have, for example, 63 milligrams per deciliter of LDL cholesterol, and we know it very well that when we add berberine, for example, because I also have a great experience with berberine or radius rise, berberine, also with few others, polycosanol as well. However, it is a little bit less, and polycosanol, in my opinion, is a little bit tricky nutraceutical, but it is probably an issue for another discussion. We know it very well that we might still reduce by 10, 15, 20%, and we might be on the target, especially in stable coronary heart disease. Do you think that in such a patient, which is asymptomatic, taking into account the conditions, which is stable coronary heart disease, when we are close to the target, it is an option also to use nutraceuticals or not? What is your opinion, Matteo?
Yeah, I think that this is an option, obviously, because, I wouldn't use a combination of monocholine K with statin. That's, I think, is a pharmacological contradiction. Anyway, but we have different single nutraceutical not containing monocholine K. So you say that the case of berberine, for example, berberine would be an option, even alone, in that patient in which you are just 10, 15% above the target after using all the drugs that we need. So you have statins, you have ezetimibe, you have anti-PCSK9 inhibitors, you arrive at the 68, you need something else, you can do this. I think whatever we can do to reach the target is an option that but if it is a sure option. So I think it will be an option, absolutely.
Okay, we have another beautiful question. I believe it is indeed critical one from Nikki. Do nutraceuticals have a place in the pediatric adolescent population with familiar hypercholesterolemia? As a kind of introduction, you know it very well that we have still very limited knowledge how to treat children with FH. When we know that we usually start at the age of 8 or 10, and we usually start with the lower doses. Then we might increase, take into account the LDL levels we have on this dose. But maybe it is an option as well to be on the target with those patients to be below 135 in children, which is the recommended target for FH pediatric population. In fact, I'm not so familiar with FH pediatric patients because I usually treat FH adults, but in my institute there are a lot of pediatric patients, and I know it very well that nutraceuticals are not used in those patients. But what is your opinion about it, Dan, Matteo, Peter?
There is an experience in Italy from a group of pediatric doctors in Turin that used the combinations, started as a bridge before drug therapy in children, to use ezetimibe along with a nutraceutical combination of the radius rise plus berberine. That may be an option in order to convince, first of all, the parents of the kid, because most of the time is not the patient, the child that refused the treatment, but is the parent. So the way in order to start something that allow them to understand the importance of reducing cholesterol safely, maybe starting with a nutraceutical, possibly with ezetimibe, you will see that, and they will see that the treatment is well tolerated. So maybe this is a good bridge in order to bring the child to a statin therapy in the years after. I think that maybe, and there is also some literature evidence on it.
Thank you what you have just said, because Indeed, when I've asked these questions, I had in mind one of the option, and it is completely clear with your opinion, because we know it very well that there is a group of parents that do not agree that his child might have a disease, genetically predisposed disease, and when they hear that the child must be treated with statins since the age of 8 of 10, they say, okay, we do not agree. Especially they can read in the Dr. Google and many other internet web pages that it might be associated with the problems with hormones, with growing, and many other different things. And we know it very well that it is not probably the issue, but on the other hand, it is also the reason we start with the low doses and we increase the dose. And they simply not to will using statins in their children, and that is why I believe it is an option to say, okay, if you do not agree to use statins in your child with FH, with severe hypercholesterolemia, or maybe it is not FH, it is simply dyslipidemia or hyperlipidemia in children during the obesity metabolic syndrome, please try natural products, which is radius rice, which is berberine, or maybe it is a combination. Because I would like to ask you about probably it is one of our questions, because it is one of the questions. Another, that would you recommend using combination of polypills or nutraceuticals? Sorry, so in the form of polypills, or maybe it is better to use berberine in the largest doses, or radius rice in the largest doses, or bergamot, or maybe others. Probably we have already responded to it during our lectures, but I would like to strongly emphasize our approach. But I believe, because I am very sure that our approach is clear, that we should use, Peter?
Combination.
The combination, right, the polypills. So, but why?
I think we've got examples from conventional pharmaceuticals that if we give more than one drug, go back to Indian polycap study at low doses, we can see effects on blood pressure and lipids without perhaps provoking side effects to the same extent. And we look at European guidelines for hypertension. That's the approach that's going there, starting with dual therapy. So we know that all drugs in the class of nutraceuticals there have a dose response curve, and if you get to the top of that, then you're likely to more likely to see adverse effects. So conceptually, using preparations that use multiple strategies to target the problem in multiple ways is very nice. I think also these preparations lend themselves well to being investigated in clinical trials. So I think perhaps branded polypills are much more likely to undergo a rigorous randomized control trial than perhaps a cheaper product that maybe contains one ingredient. I think so. Yeah, I'm enthusiastic about polypills for nutraceuticals.
The funny thing is, I would like to ask also for the opinion of Dan and Matteo at the end of this, because we are going to the end, that we have just started in Poland few cohort studies and some studies, prospective studies, let's say, about the polypills, in which we have, for example, berberine, which is very effective in the LDL cholesterol reduction, as well as has some additional anti-inflammatory effects and antioxidant effects. We have also plant sterols and stenols in one polypill, and on the other hand, green tea, which is very effective in the reduction of the blood pressure and in the improvement of the vascular stiffness. And on the other hand, we have as well other nutraceuticals, which are hepatoprotective and might reduce, for example, aminotransferase and so on. So they combine all the properties in one polypill. We might have much better effect, because from the other side we might reduction of LDL cholesterol, from the other side we have the reduction of the blood pressure and so on. So I do believe that this is the only way in order to use effectively nutraceuticals in the form of the well-designed polypill. I believe that our Lipid Plus is obviously one of the examples, because such polypills are at least few I know, but I believe it is the best way in order to convince doctors and physicians that this therapy might be helpful, first of all, still safe, and this therapy might help to optimize and being on the target with our patients. Matteo, then the last words at the end of the webinar, so the floor is yours, and I say goodbye after your words.
It's Dan. I don't know if Dan is present because I can't see him.
Yes, I am. Yes, I am, but I have problems
with the connection. That is why the camera is, the video is off.
You, Dan.
Dan,
for sure, if we want to have nutraceuticals as a supplement, it's not necessary to have studies. But if you want to replace as a drug and to treat and to decrease, we need this type of studies as you suggest. This is a clear cut. Thank you.
Okay, thank you, Dan. Matteo.
Yes, I would add just another concept, that is adherence, the long-term adherence to a treatment. So we know, we have learned from statins, from each drug reducing cholesterol, that long-term adherence is very important. If you lose adherence, you will not have the effects on cardiovascular events that you are expected to have. So the same things should be applied to nutraceuticals. It's very important. If we start to use a nutraceutical, we have to demonstrate and to warrant adherence in the long term, because long-term adherence with a mild reduction in plasma LDL cholesterol since the 40 years old for 7, 10, 12 years may have a profound impact on a very important impact on cardiovascular events. So long-term reduction, long-term mild LDL cholesterol reduction may have a very important effects, as Maciej already recalled to us. So we have to allow our patient to take the right therapy, but also we have to control and to check that this therapy is continued to be done for a long time if you want to have an impact on cardiovascular events. That is what we want to have.
So first of all, I would like to kindly thank you for being with me and during the second ILEP webinars on nutraceuticals. If you don't mind, I will say a few words about the nutraceuticals we have emphasized during this presentation and discussion. First of all, quality of production. Second, we should use only those nutraceuticals we are sure that it is not contaminated with other products that might influence adverse effects of these nutraceuticals, because then we do not have the real safety of the nutraceuticals we use. We should try to use the nutraceuticals with the confirmed efficacy, because, for example, Poland is the largest market of the supplements, diet supplements, and most of Polish population use diet supplements without any evidence-based medicine, because they much prefer using diet supplements in comparison to pharmacotherapy. What is important? We shouldn't replace pharmacotherapy with nutraceuticals. So if we have indications to use pharmacotherapy, we shouldn't replace it with pharmaceuticals. So if your patients say, doctors, stop statin, I will take instead of statin nutraceutical, it is not the correct approach for sure. Finally, I believe it is very important to take into account, to summary, the groups of patients that might benefit the most. So statin intolerant patients, or statin not adherent, or those who are not willing to use statins, because it is another very important group of patients. Statin in the primary preventions without indication of using pharmacotherapy, or those who are at the low or moderate risk, who are close to the target. And we know it very well that, or even high risk who are close on the target, we know it very well that using nutraceuticals, especially those nutraceuticals in combination in polypill, we might help to be on the target. Obviously, completely another issue is the secondary prevention, which is still a matter of discussion. And I believe that taking into account that for secondary prevention, we should be as low as possible. Nutraceuticals will be used probably much less often. And finally, the thing that Matteo said at the very end, that nutraceuticals might help us to be adherent with the LDL cholesterol reduction. And it is a problem for other drugs. Obviously, we have been waiting for such drugs like inclisiran, which help us to be much more adherent to, for example, in comparison to statins. But on the other hand, waiting for inclisiran, having in mind that inclisiran will not be indicated probably for those patients like we have been discussing now for nutraceuticals. I believe nutraceuticals might be indeed a very useful option to be adherent with the therapy. So then, Peter, Matteo, it was a great honor and pleasure to have you during this discussion, during this webinar, and trust me, it is not the last webinar we have been together. So let's be in touch, and hopefully we will be able to meet very soon. So have a good evening to everyone, and thank you to all the participants that were with us. And we meet on the 1st of October for the second webinar of Nutraceuticals with Professor Zlejko Reiner from Croatia, with Professor Arrigo Cicero from Bologna, from Italy, and with the beautiful Professor Niki Katsiki from Greece, our great friend and colleague. And I'm looking forward to having this webinar. And good night, good evening, and thank you very much. Bye bye.
Bye.